about, and again, see how this nicely, the video streams tie very nicely into what your textbook has, doesn't it? It talks about in the frontal cortex how pain is perceived, how we think of pain. We have this thing called pain threshold. That's the point where the brain recognizes and defines it within itself what that is in terms of the stimulus. And then we have what they call pain tolerance. That's the duration. How long is that person willing to endure a certain pain? But remember this, everybody's an individual, just like we do these individualized care plans, right? They have standard care plans, but we individualize them. We individualize them to each and one of the patients that we take care of. And thereby we must consider pain very individualized. It's what that patient says it is. They talked about in those video streams about the pain modulation systems. We have this thing called endorphins. We actually produce within our own body our own morphine. We actually have our own morphine producing factories. And then of course they talked at some length on both of those video streams with Melzack about the gate control theory. It was mentioned earlier about that substance P. The substance P is linked with those endogenous types of pain receptors, that body producing opiate mechanism. Y'all didn't have that slide. I found the picture. It was sort of inspired me to put that. And it doesn't have anything to do with your test, but just look at that, the image. You know, that sticks in your mind. The image of a child that has sprung their ankle. It's very painful. I mean, doesn't it hurt? It hurts me. I was that kid. I used to sprain my ankle a lot. Painful as a kid. Those endorphins, they flood in when that pain, they try to help ease the hurt. Our own body has that ability. And then again, emphasize about the gate control theory. We probably have a lot of the soldiers that, I mean, there's probably a lot of pain research going on within SAMC. My guess is that there must be a lot of research. I want to just emphasize one more video about the gate control. As I can say it better than I can.
Ronald Melzack was born in 1929 in Montreal. His parents were working class, and he was one of 3 boys. The family didn't have the means for all of the boys to pursue a post-secondary education, so Ronald went to university while the brothers worked at the family bookstore. It's been said that Dr. Ron Melzack has done for pain research and pain management what Einstein did for physics.
Well, Ron Melzack has contributed very fundamental basis of our physiological and psychological understanding of pain. At the time when Ron Melzack and Pat Wall were first writing, pain was a fairly small, somewhat obscure field of neurophysiology. Now it's one of the major fields.
Pain is very valuable stuff. I think it is such an essential part of our human life.
After time spent at University College London and the University of Pisa in Italy, Dr. Melzack joined the faculty at MIT in the early 60s. He and his colleague, Dr. Patrick Wall, developed a groundbreaking gate control theory that would initiate a new era of research around the globe in numerous fields.
I think that the gate control theory explained a lot of observational facts which have been floating around rather vaguely. without really coming into focus, you might say. What the gate control theory provided was a mechanism, or the possibility of a mechanism, where under certain sets of circumstances, it might be that the pain message, if you like, from the toe to the brain just never got there.
That is the great breakthrough. When Pat Wall and I proposed the gate control theory of pain, it was nerve impulses from an injured area in the body going into the spinal cord, and there was what we called a gate. So if you were busy thinking about something else, the gate might be shut. You might not even feel the pain. And then the gate can be wide open. You are anxious and worried about something, and your pain is enhanced, or along with your pain comes a stress. So now what we have is a real field of psychology, and psychology is now an integral part of the pain field.
Dr. Melzack is also credited with the development of the McGill Pain Questionnaire, a clinical tool that, once established, quickly became the gold standard used around the world for measuring pain in clinical research. Much of his foundational thinking for the questionnaire came during his postdoctoral work with Dr. Livingston in Oregon, doing research with patients suffering from a variety of chronic pain, such as phantom limb pain.
Ron Melzack's McGill Pain Questionnaire was really a major step, because previous to that there really was no widely accepted measure of pain. He was working with patients who had pain problems, and that's of course how he developed, from a scientific point of view, developed the pain questionnaire, the McGill Pain Questionnaire, which is used everywhere.
It has now been, the McGill Pain Questionnaire has been translated into over 50 languages. So we now have more than 50 translations of this.
After returning to Montreal in 1963, Dr. Melzack's brilliant work as a basic scientist, coupled with his deep empathy for patients suffering from chronic pain, led him to be the driving force behind the ultimate opening of Canada's first pain clinic at McGill.
He floated the idea of a pain centre in what's now the MUHC, and he met with a lot of enthusiastic support from them.
It's just going to talk more about the center, but I have purposely given y'all these videos because I want y'all to realize we can do more to help our patients with their pain, and we typically overlook it. We just do overlook it. Ryan, please share what you told me while this video was going on.
I worked in the burn unit, and
At BAMC, or SAMC. I guess
SAMC
it's
now,
SAMC
yeah.
now.
They took us over. But how they found, like, when you got the burn patients, you can't really stop their pain because otherwise you'd have to sedate them. There's no way to stop the pain. Everything they do is massive pain. So they found that in order to treat the pain, they use distraction. They get a virtual reality machine, they put it on their, not touching their face, obviously, if they got 100%. And they got a controller that they can just barely touch. And they go through like skiing, they put them through different virtual reality exercises, and they find that reduces their pain dang near as good as medication does on almost all of them.
A virtual reality, like what?
Like, you ever have the virtual reality? It's like 3D.
You put on your glasses?
Yeah, you
I know
put
what
on
you're
the
talking
big, yeah, I did one in the needle. I've had one.
It's in a way, see,
Feels like
it's-
depth perception.
and it's distracted them into some other kind of thought process to where their focus isn't now just on that pain, it's actually on what they're doing with the reality or the virtual reality that they're engaged in.
What is the virtual reality? What are the examples of the game?
Like the skiing one is the one we got to see. If you ever got a chance to look at the Center for the Intrepid too, they got some really cool stuff. They do tours, but in the burn units, they only do it for the burn patients because the equipment is so expensive. Like they'll go skiing. It's not like a serious video game. Not like shooting.
Do they have multiple like versions of it?
Yeah, they got more than the skiing one, but that's the one we got to see, and it was really cool. They actually, you know, it's 3D. It feels like you're in it. Everywhere you look, you see it, and they can't really move their head or they got pins all over their body to keep them from moving in the very beginning, and that helps. That helps you do the morphing. So that was great.
Yeah. A lot of stuff. So let's talk about pathology of pain, and I thought we would throw in a scenario here of what happens when pain goes untreated. So that's a picture of my husband playing music. So I can give some life, some real life, quality to this scenario I've created. So Mr. Moore, he's a 54-year-old. He's been admitted to the med-surg floor, and he has previous history. And if you start having me in classes, you'll know that Mr. Moore will always be the patient in my scenario, and he's had every disease known to man. And he's died, and he's even come back to life several times. But in this scenario, he has a previous history of type 2 diabetes, irregular heartbeat. He has atrial fib, which y'all have already just remember as a regular heartbeat. He has an irritable bowel. You guys have been, at least you know about that from previous session, diverticulosis. And he's had some recurrent bouts of diverticulitis. See how I'm tying the two chapters together. In his current hospitalization, he underwent a hemicolectomy. He had to have some resection of his bowel the evening before, and he arrives to your floor from the recovery room at 1 o'clock in the morning. And you come on shift at 7 a.m. and you do your initial assessment and discover that Mr. Moore is in severe pain, and you ask him on a pain scale what it is, 0 to 10, and he says it's an 8. And he also says that has had this pain since arrival to the room, but he thought he was supposed to expect this pain, so he really didn't tell the night shift nurse, and maybe they didn't really offer to ice him. So let's see what happens when we ignore the 5th vital sign. And I came up with this design, but I want y'all to remember this. I mean, it took me 2 hours to create this one slide. So let's talk about it. And I want y'all to remember this slide, because you're going to see when you go to Adult Health 1, you're going to have a situation on one of your simulations that's going to deal with the concept of pain and what can happen to a person when we ignore pain. But so he had a lot of stuff going on, right? But in the essence was he was post-op and he was in pain, and we didn't address it. So we didn't address his pain. So initially what we find is when you're in pain, what happens? Let me use my pointer so I can make sure I cover all the paths here.
Everything
Hey,
hurts.
how are you doing? Yes. I'm giving them the scenario on pain management. He's Adult Health 1 student. He knows what pain is when he goes through that simulation. Okay, so your heart rate goes up. Your respirations go up. When your heart rate goes up, you don't have you lose that feeling time of your heart. You know how your heart, your diastole part of your heartbeat, that's the time that the blood feels. The systole is the contraction, right? So if your heart beats faster, you lose some feeling time for your heart. You see what I'm saying? So when you lose the feeling time of your heart, you get less blood in the heart to pump out. So when you get less blood to pump out, you get, it's a vicious cycle. You've got to maintain, you're trying to maintain your body system. So in order to maintain your body system with this vicious cycle, your heart beats faster. And as your heart beats faster, it increases your cardiac workload. You're working faster. Your heart's having to work in overtime. but it's a vicious cycle that does not really, it will succumb eventually. You get less blood flow to your coronary arteries. It's not getting as good a blood flow because why? We're just working so hard. Our heart's working so hard. When we work so hard, we decrease our cardiac fill time, which leads to a decreased contractility. We don't have this as a positive influence. We're not getting as much blood out to the body. We, in essence, decrease our cardiac output, which y'all haven't learned yet, but cardiac output is very significant because that demonstrates, or that's another segue into our hemostasis of our whole body. When you have poor cardiac output, the rest of your organs start suffering. So then we have decreased cardiac output. And when we have decreased cardiac output, we start affecting our other organs. Our other organs, such as we start not getting as much blood supply to the kidneys. So when we start getting not so much blood flow to the kidneys, we start having renal insufficiency. We might start having some acute renal failure because we are not getting enough blood supply to our kidneys. Our kidneys in turn try to say, man, I've got to do something. So what it does is it evokes that renin-angiotensin-aldosterone system to kick in to increase, and therefore we reabsorb sodium and fluid. We retain, so we're putting more, we're retaining fluid, our heart's beating faster, but it's not as powerful. It's not as good. So what happens is then the fluid starts backing up into the lungs. We start developing fluid in our lungs. We start having more trouble breathing. We already spoke to the concept of increased respirations with pain, because when you have increased respirations with pain, you have a shallow type of breathing pattern. Post-operatively, when we have an increased respiration because of the pain, we're not breathing deep enough. So therefore, we put ourselves at risk for atelectasis. Post-op pneumonia types of things. When we have decreased cardiac output, we're also affecting blood flow to the cerebral arteries. We're getting less. We can then have a situation where we'll develop increased confusion because why? What's the two things that the brain needs? Oxygen and glucose. So we're decreased oxygenation leads to increased confusion. And so it's a double whammy because of the cardiac output being affected, because of the pain, because we get medicated, see. But see, the increased respirations are not quality respirations. So what in essence happens, they get hypnic, not good quality exchange, so it basically, the oxygenation within the system's decreased while we're building up more CO2. And that also affects our confusion. The other thing is when we're not getting enough blood flow because our decreased cardiac output, because of the pain, because we didn't medicate, we can start seeing decreased blood flow to our arteries, and then we start seeing problems with our gut. Our gut shuts down. We'll have developed paralytic ileus. You see all the problems that can happen. And if we don't fix these things and we just let the pain go on and on, we can throw our body into acute shutdown. I talk about the excess fluid because of the system. It retains, it forces us because it's trying to overcome the fact that we're having decreased blood flow to the kidneys because we didn't get, because decreased cardiac output because why we didn't get enough pain taken care of. So this excess fluid starts backing up into the lungs, and we can develop respiratory compromise, respiratory arrest, and then death. That's what can happen to us. That was my 2-hour slide. You guys remember this slide. Y'all save these PowerPoints, because I guarantee that you're going to have something in your adult health 1 that's going to be some sort of scenario of maybe a 62-year-old lady that came in that had a simple hip fracture. And we elected not to take care of the pain. And see how this thing was, we thought it's a simple process, but it's not at all. Look what happens to us. It can kill us. Pain can kill a person. Those sympathetic responses, we talked about that. Increased blood pressure, heart rate, respiratory rate. We talked about that increased respiration is not good quality respiration. And here's just an example I threw out there about the patient that's had a motor vehicle accident, MVA's motor vehicle accident. That's what that stands for. They'll do something known as the term splinting because it hurts. It hurts to breathe, you know, where they've had these fractures. So in essence, they are not expanding their lungs. They're not getting a good exchange of oxygen, and that in itself can lead to atelectasis, which can in turn lead to pneumonia, and then they can develop what they call respiratory acidosis, and that's deadly. The things that can happen because we don't take care of pain, you see. And how do you assess it? You look at nonverbal signs. Are they grimacing? Do they look ashen? You can see this stuff. You can see on the monitor the elevation of the heart rate. If they're on a cardiac monitor, you can watch it climb. Physically take their blood pressure. Sometimes they say though, with chronic pain, because they've had to live with it so long, you'll actually see some opposites. And in a way, if you think about chronicity of pain, they would tend to have lower blood pressure, lower cardiac output, feelings of faint, because why we've let this go on for so long that now their parasympathetic nervous system has kicked in. But in the acute phases of pain, it's just sort of, think about yourself when you've had the worst situation of a pain experience. You felt the intensity of it. Then we talked about, and you guys have seen, even at your facilities, that they do use a variety of pain scales. The one that we're most familiar with is on the scale of 0 to 10. Can you rate your pain? We don't really delve into pain like we should. We make that be a haphazard. On a scale of 0 to 10, where do you rate your pain? And then we move on. We need to be a little more involved in pain. I think about all these patients, and at every nursing home that you guys are going to, in every nursing home, there has to be patients there that have some amputations. Am I correct? Do we really, I mean, have any of y'all taken care of those patients? And have we, do we go that much into talking about pain with them? Have you noticed that they do have PRN orders for phantom pain? We're doing better than maybe what we used to do, but we just really didn't used to cover this. I can imagine with SAMC, that they are very engaged in how the assessment of pain, because we've had so many soldiers with those explosives that lose their limbs, you see. it has to be that has to be a mecca of pain research going on within the military over there.
They just tell us pain is weakness leaving the body.
Huh?
Pain is weakness leaving the body.
It's what now?
Pain is weakness leaving the body.
Weakness leaving the
That's
body.
what they tell us.
Well, maybe that's their distractor. I don't know. Could be they're trying to use that. Maybe they're doing some sort of research study on if they can convince you.
Dr. Moore, what happened what tragically happened to make them start using pain as they start noticing pain is serious, like it is now part of vital
I think
signs?
the research. I think
Because
I think the
usually
break-
something bad has to happen for you to.
I don't know. I just think over and over the research. I think that Melzack was the, and that's why I played so many because I think, and you see, it wasn't really that long ago.
Right.
It really
you just
wasn't.
started putting it.
We're just now, and if you think about when I started in nursing, we didn't have the fifth
Right.
vital sign. So that's
Okay.
25 years ago. This thing sort of evolved, since I've been. So you see how important this has become. I think it's through research. They've uncovered the fact that, oh my gosh, we've just totally overlooked this, and that's why people can't get better. Maybe somebody's done studies to show if we keep our patients comfortable and out of pain post-operatively, they recover quickly. They're the ones that get up and they're ambulate. Yeah.
I just have to ask, because how did Melzack know that the dogs and the lab rats were pain subjective?
I don't really know the specifics of the rats, the mice.
Both of them were
I
feeling the same.
I will say something though about we have a lot of dogs. We have 5 dogs in our backyard, but we noticed, huh?
So you want 2 more?
No, we can't, that's the limit. But we've noticed that when one of them's feeling ill, that the others will come up and they will care for that dog. They will lick that dog to make that dog feel better. We've just noticed that.
Well, it's been around. Dogs know, like when
They
their
come-
master's in pain, they always
Yes, and
be
they come
sympathetic.
and
Look
they're
at
sympathetic.
Marley and me.
But see what and I know, but we observe this with our dogs. Say, isn't that how caring are they taking care of one another, trying to help them through their pain? We had, we've had a couple dogs that have died. And this one in particular, we have this border collie that she's with us, and she's now the boss. But she used to be the puppy. But when the elder dog was dying, she stayed right to her side and she kept licking her. The distractor, that she was comforting her and giving her that type of distraction, sort of like in a way, it was like what Ryan talking about, that virtual. You see and it's such a simple thought that why didn't we think that this sooner for our patients? See, we did. We just did. The importance of being able to listen to what our patients say about their pain. We should not discount them. I don't know if you want to share that. You had that story you told one time about your pain are you,
Yeah, sure.
tell them a little bit.
When I was in launch school, right after I got injured, while I was being medevac back to the States, I had a surgery that did a nerve block and then left me alone for 10 hours. And by the time I woke up from the anesthesia, the nerve block had worn off and my arm was killing me. I told the LVN, this Army captain, she medicated me, came back 40 minutes later, I told her it was still out of control. I was sobbing, I was pretty hysterical, and she blew up at me. She was like, I know exactly what you're doing, I've seen this so many times, you just want more pain medication. Rah, 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 and was screaming at me,
they got
and
that bad.
as she's screaming at me, the night shift nurse, a Navy commander, just comes in the doorway. And I started looking over her shoulder at the commander, and she followed my line of sight, and that commander just beckoned her